Webinar is part of the Provincial COVID Rehabilitation Provider Education Series. Today, we will be discussing the topic of resuming physical activity and exercise after COVID-19. My name is Laura Bernard, and I work with the Allied Health Professional Practice and Education team, and I'll moderate the session today. We are very excited to have such great interest in these sessions. Because of the high number of participants, we ask that you please keep your audio lines muted. Please use the chat function to type in any questions. You can find that on the bottom of your screen near the middle. Please use a direct message to questions. I will change my name to questions and will send a message to the group from that in the chat shortly. I'll collect the questions and bring them up at the end of the session. We will record today's session. It will be posted on the internal AHS Allied Health Practice Hub, as well on the external recovery and rehabilitation page after COVID-19. I will add those links in the chat box shortly. This webinar series is open to all healthcare providers. These sessions are focused on the biopsychosocial and spiritual perspectives of post-COVID rehabilitation and recovery. You are encouraged to tune in to as many sessions as possible, as we believe that each session will be an opportunity for new learning. The companion clinician resource that will be described later in this presentation is seen as a living document and will be updated as new information or content becomes available. I am pleased to introduce our speakers today. Caitlin Troop is a physiotherapist and senior practice consultant with the Allied Health Professional Practice and Education team. Lauren Singh is a physiotherapist with the Pulmonary Rehabilitation Program in Calgary on the Community Accessible Rehabilitation team. She has been providing care to post-COVID patients in her outpatient role, and along with her team has been integral in developing the clinician resource document. And finally, Catherine Regan is a physiotherapist at the Royal Alexandra Hospital who has worked on one of their COVID units in the past few months. She's been working in acute care for a number of years and has experience in different programs and services. Her current work is on the medicine program. With that, I'm going to hand it over to Caitlin to get started.
Thanks, Laura. So as Laura mentioned, these webinars are intended for AHS providers, but they are open to everyone. We do encourage people to align the material presented today with their own clinical policies and procedures. Please note that this session, along with the question and answer period, will be recorded. Along with all of our webinars, every effort has been made to incorporate the best current evidence and information available. But as we know, information around COVID-19 is changing rapidly. If you have any questions or concerns about the content of today's webinar, please email practice.consultation@ahs.ca. We also wanted to take a moment to acknowledge that yesterday was National Indigenous Peoples Day, and there'll be ongoing celebrations happening throughout the month of June. We acknowledge that we are gathered virtually today on the territories of Treaty 6, Treaty 7, Treaty 8, and Métis Regions 1 through 6. These territories are home to many Indigenous peoples, including the Blackfoot, Cree, Dene, Tsutano, Ojibwe, Stoney Nakoda Sioux, the Tsuut'ina people, the Métis Nations of Alberta, and the 8 Métis settlements. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. We also wanted to take a moment to acknowledge all of the healthcare providers that helped contribute to the provider resources and the webinars. In particular, we wanted to thank our PT colleagues who helped us pull together this presentation, including Andrea Pierce, Dana Downing, Fern Lee, Heather Zygan, Kira Ellis, Margie Hawes, Safia Rajan, Sarah Arsenault, William Tung, and my co-presenters here today, Catherine Regan and Lauren Singh. We also wanted to take a moment to acknowledge the AHS staff and physicians and specialists from across the province, including Dr. Ellie Stein, Dr. Ian Patterson, Judy Kay, Lorna Nicholson, and Darren Brown from the United Kingdom, who helped us create these resources and provide them to you in an Alberta context. In terms of an overview for today's presentation, we'll talk about some of the biopsychosocial considerations when working with COVID-19 patients. We'll provide a definition of physical activity and exercise. We'll touch on some of the key considerations for resuming exercise after COVID-19 and the foundational elements of treatment. And then I'll pass it over to Lauren, who will talk more about treatment considerations from a community perspective. And Catherine will speak to treatment considerations from an acute care perspective, and both of them will provide case scenarios as well. Before we jump into our treatment recommendations, we wanted to just mention the importance of approaching COVID-19 patients from a biopsychosocial perspective. As we all know, the biological impacts of COVID are significant, but we can't appropriately progress patients through rehab and recovery without considering some of the psychological, social, and spiritual impacts of the condition as well. Since the start of the pandemic, many people have been impacted by social isolation, and their regular routines have been significantly impacted. So a lack of social connection, limited employment and income, and feelings of depression and anxiety are common. And these factors also contribute to one's overall health and well-being. So it's really important for us as rehab providers to acknowledge these issues in order to help optimize recovery in our patients. On this slide here, what we wanted to do is just provide a bit of a definition around what we mean when we're referring to the terms of physical activity and exercise. So in the context of COVID-19, we often hear people talking about return to physical activity and return to exercise. And I think depending on the clinical context, sometimes these terms are used interchangeably. So we wanted to make sure that we had a solid definition so you understand what we're speaking about as we go through the presentation today. So the term physical activity is defined as any bodily movement that results in energy expenditure. And it may include things such as activities of daily living, household and employment activities, sports, or conditioning. Exercise, on the other hand, is a subset of physical activity that's planned, structured, and repetitive in nature with the objective of being to improve physical fitness. So exercise activities might include strengthening, range of motion, balance, and aerobic training, and some of the common modalities that we would use commonly in our physio treatment practice. So in terms of COVID-19, recovery and return to physical activity and return to exercise are both important factors, but we do want to highlight that return to exercise shouldn't take precedent over return to physical activity. And what we mean by that is it's really important not to prioritize exercise until a patient can safely complete all of their activities of daily living without worsening of symptoms. That being said, it is important to take the client's goals into consideration. So we recognize from a wellness standpoint, some patients may want to prioritize exercise over some of their regular activities. So for example, if they want to participate in a yoga class to help them with their mental well-being, and that's more important to them than doing laundry for the week, we have to work with them to make sure that we are helping them achieve their goals and helping them direct their energy appropriately. And with that, I'm going to pass it over to Lauren, and she'll speak to some of the key considerations of resuming activity and exercise, which we spoke about in the first presentation.
Thanks, Caitlin. Yeah, so we're going to talk a little bit more. If you guys were in the presentation 2 weeks ago, a big focus was looking at those 5 safety pillars that we want to highlight and be considerate of as we move forward with rehabilitation. And so they're listed here, and we're going to get into them in a bit more detail. And so it's just to say that we work in many different rehab contexts, and everybody has their unique skill set. So I will certainly not tell you how to do your job or the best way to treat patients in your specific realm or discipline, but just kind of how these things may have some interplay with how you deliver care to patients in a post-COVID-19 context. And so this is just like a flash of the screen, which is Appendix A in the guidance document that's been written. And so we'll look at different pieces of this. So just to remember that it is there, and it is kind of the foundation of how we approach safe rehabilitation in a post-COVID-19 population. Okay, so again, the foundation of how we're going to deliver care in all these different pillars is pretty synonymous across the board. So the foundation of the work we look for is symptom stabilization. Rehabilitation should be restorative, full stop. And a focus of what we do should not be exacerbating symptoms. And so sometimes that takes us wrapping our heads around the idea that rehab is not synonymous with exercise and physical activity. Sometimes there are other holistic approaches, education, connecting and wayfinding that might help best support your patient as they kind of move through the trajectory of their care continuum. And so as a foundation of all of those different pillars we're going to look at, these are kind of some of the pieces. So symptom stabilization, breath awareness is a big piece of it, and breath control. And it is about optimizing efficiency. If you're a better breather, you're optimizing efficiency in energy budgeting because it takes a lot less effort to be able to breathe well. It's a non-invasive mechanism to be able to support your patients. It directly relates to autonomic function. And more importantly, it gives patients a sense of control and self-efficacy if they're taught how to breathe. And it's a pretty low risk, high reward type of intervention. So teaching somebody how to breathe, you're never going to go wrong with it. A foundation of all of these other pillars is screening, and so that's that tool, making sure that we are safe in our rehabilitation approaches. And then demonstrating at the core of everything we do as clinicians, empathy and validation of the experiences people have had. There's so much uncertainty. There's uncertainty of the clinical trajectory. There's uncertainty in terms of best practice. There's uncertainty as to outcomes, and that can be sometimes a very difficult and challenging place to come from as a patient. And so empathizing and validating the experiences people are coming to you with is important. So if we look at the first pillar, in my mind, the most significant one for rehabilitation is post-exertional symptom exacerbation. And again, it's that relapse, remitting, episodic presentation of worsening of symptoms as a response to physiological or cognitive activity. The screening tool that we have in place is the DePaul symptom questionnaire and the post-exertional malaise subscale, which has been validated in other chronic fatigue populations and is being recommended as the screening tool to tease out PESE in a post-COVID-19 population. The guidance on intervention is going to be symptom titrated physical activity, so not exceeding what individuals are capable of without symptom recurrence. Again, coaching breathing foundations as a mechanism to provide self-efficacy, but also optimizing energy, and coaching rest as an activity, and then last week's presentation from occupational therapy supporting energy optimization, and perhaps using an activity log to help people track their symptoms. And so symptom stabilization and continued monitoring is one of the most supportive and appropriate approaches. And as rehab clinicians, this is the area that we have the most potential to cause harm. So prudent screening and continued monitoring is of utmost importance, and following up on interventions. How are people doing the day after or the days following what you do if they are crashing or they're having symptom recurrence? So not just fatigue or malaise, but perhaps shortness of breath, a headache, a hoarse voice. Some people have a cough, and that's again symptom recurrence as a byproduct of too much stimuli or too much activity, and perhaps a regression. In a pre-publication that was released very recently in Alberta, there was a survey done of people that consider themselves long haulers or suffering of long COVID, so symptomatic post 6 months. And 60% of participants actually met the scoring threshold, which would be used for myalgic encephalomyelitis or chronic fatigue. And so if nothing else, there is a very clear global call to action that graded exercise therapy in the context of post-exertional symptom exacerbation is counterproductive, and it can cause harm. And that being able to prudently screen your patients and prescribe activity or rest it underpins supportive and appropriate care for those patients. It's on CBC this morning, actually. So it is a very real and tangible thing for people that are living with the physical and social experiences of long COVID. And so this was released as an updated on the statement that graded exercise therapy can be counterproductive. And so use the screening tool and please be prudent. Another pillar that we look at is cardiac safety and cardiac impairments. That can present as peri or myocarditis, thromboembolic disease, and sometimes those symptoms that we may see in a rehab context are palpitations or inappropriate tachycardia, chest pain, marked reduction in fitness, and disproportionate breathlessness. It's not necessarily a red flag that people cannot participate in therapy, but it is certainly important that we exclude any kind of cardiac impairment in order to be able to prescribe exercise or prescribe rehab in a very appropriate way. And so in definitions, we're looking at an elevation in serum troponin, and we're seeing it in up to 45% of inpatients, and it is associated with poor outcomes. So we know it's coming, especially in that population that has been hospitalized. So in the screening tool, we have questions about heart racing with simple activities or chest pain with rest and exertion. And those would be kind of your red flag indicators to send back for further investigation so we can ensure that the therapeutic intervention is the most appropriate intervention. And so when we're looking at interventions and how to refer your patient appropriately, if you do happen to see them or you're helping them along the continuum of their journey, cardiac rehab is a really excellent resource if it's appropriate and available. Conservative intervention. Now, I know as a physical therapist, like I really badly want a heart rate target or heart rate parameters. And unfortunately, there is not enough evidence to support giving really like a frame. And so the suggestion has been to start at a post-exertional malaise or a PESC intensity and titrate up as tolerated, and trying to work below anaerobic threshold to start as calculated here and available in the document. There are a handful of guidances that have been written by the consensus statements from Canadian cardiologists about return to sport. Now that's a lot in athletes, and we hear it all the time with athletes returning to sports, that they've got to clear their cardiac red flags. So there are some guidelines there, and the ACSM has guidelines for how to deal with people with cardiac impairment. But it is quite important because we want to appropriately prescribe exercise to people that have peri or myocarditis or have cardiac disease or injury, because if we don't do that appropriately, there is a higher and increased risk of morbidity and mortality. For those of us who are working in return to work situations, there is the suggestion that we look at continuing monitoring for potential delayed development of dysfunction. And especially if we are going to be facilitating a return to work of strenuous work, we need to explore the possibility of persisting low-grade cardiac injury. One of the other pillars that we are looking at from a safety perspective is exertional oxygen desaturation. So in our Alberta context, we're qualifying that as a drop of oxygen saturation of greater than or equal to 5% or below 90% for people without lung pathology. The screening tools that we're going to use for that are a 6-minute walk test, 1 minute stand test, and a 2-minute step test. What you may notice is that those are all submax tests that require a considerable amount of exertion and effort. And so it kind of highlights why that DePaul symptom questionnaire for post-exertional symptom exacerbation is at the forefront, because if individuals are screening positive for having that chronic fatigue presentation, then probably doing a submax exercise test is not the best course of action, and some clinical judgment may be used to try and tease out that exertional desaturation piece. So just be aware that, if you are going to submax test your patients, if they are having that symptom exacerbation presentation, that exercise testing is perhaps not the most linear place to go afterwards. So again, just to highlight that if someone is actually meeting that threshold of oxygen desaturation, they need to be sent back to primary care for further investigation and workup, because you cannot train a hypoxic or hypoxemic patient. And all of our rehabilitation should aim to prevent desaturation on exertion, even when individuals are on supplemental oxygen. So they may require some form of breathing retraining, education and breath awareness, and introduce activity with breath control, so they cannot spiral with their breathing rate. And pulmonary rehab is available across the province and virtually as well. So if you do have somebody that has been referred to you, they are exertionally desaturating, feel free to consult or refer to your local pulmonary rehab program. And a lot of that criteria is on the Alberta referral directory for how to get in touch with your local program. And if you are treating an individual, just as a side note on supplemental oxygen, ensure you have titration guidelines. So what are you trying to target? Use continuous rather than pulsed flow if it's available. Use your lowest flow to maintain saturations greater than 88. And obviously if they're topping out at 92, then that's your window, usually 88 to 92. And if you do need support in terms of navigating supplemental oxygen use, there are AHS oxygen modules available. And then if your patient is desaturating and you're like, what do I do with this? And Is it true? There are some things that might throw it off. So just check the warmth of hands and circulation. They're wearing nail polish, they've got clubbing or Raynaud's. You may not be getting an accurate peripheral reading. And if you have the availability to use a head probe as opposed to a hand probe, that will give you a better, better insight into like true desaturation, if you just want to check. Okay, so heading into our fourth pillar, dyspnea. Dyspnea is perception of breathlessness. And so it encompasses a lot of different facets of the human experience, whether that's physical or it's psychological, that can create a dyspneic or shortness of breath presentation. And it's often characterized as being unpleasant and uncomfortable. I mean, yeah, if I ran like 10K right now, I would be uncomfortable and dyspneic. So it is understandable that if you're feeling like this, it is uncomfortable. And it can have so much interplay from so many different pieces. And so looking at your patient again holistically is important. And sometimes they might characterize it. They might come to you and say, my breathing is difficult, or it's labored, uncomfortable. They feel like they're air hungry. So if you ask your patient, do you have difficulty breathing? And they reply, yes, this is probably a path you want to go down. And we know that in some population, dyspnea can interfere with general activity more than pain. So when we're talking about quality of life, interaction with life, and interaction and proficiency or success in rehab, dyspnea can have a very marked influence. So in an Alberta context, we are suggesting that we screen for significant dyspnea because patients can self-refer to rehab. So in some perhaps larger centers, or if patients have gone through primary care, they may have been worked up already for why breathlessness is presenting. So some of the chest x-rays or pulmonary function testing, maybe there's imaging available. Maybe they've already been assessed for exertional desaturation in hospital prior to discharge or in an outpatient setting. But for many of us, patients can self-refer to us. And so because we know that, yes, dyspnea can be caused by deconditioning or a breathing pattern disorder, it can also be caused by thromboembolic disease, cardiac disease, respiratory disease, upper airway dysfunction. And so we just want to make sure that we are covering our bases for when people are presenting with breathlessness, because that is considered a very significant cardinal sign. So we're suggesting that you use that adapted MRC breathlessness scale that we just saw on the last slide. And so this is on that screening tool to help kind of navigate what to perhaps do with how your patient is screening. And just as a side note, it's a very good longitudinal measure. So if you on intake, you do this with somebody and they score a 3, you can come back at the end of your intervention or perhaps halfway through and ask them again, and they may give you a different score because we do have an MCID of 1 point for this. So it is actually a very good longitudinal measure that is used across the board in pulmonary settings. So in the context of just general ambulatory outpatient physical therapy or rehab interventions, in the absence of sinister etiology of dyspnea, so respiratory disease, heart failure, upper airway dysfunction, et cetera, you may be seeing hyperventilation, and that's usually an abnormal ventilatory control. And sometimes it can be an unconscious and learned response to some kind of stimuli. So for example, if somebody had an acute presentation of COVID-19 and they were admitted to hospital, or even if they stayed at home and it was characterized by shortness of breath, they may have assumed a position and a posture and a pattern that would have supported that air hunger or that shortness of breath. And while they may have healed or gotten over that acute infection, that unconscious or learned habitual pattern may have some carryover. And so they may be limited by shortness of breath, and it doesn't actually have a really clear physiological impairment. It's just a carryover of dysfunctional breathing, which now has a marked influence on somebody's life. And so as a clinician, sometimes we want to be able to link how people are symptomatic or what they're experiencing to a very specific impairment. And in this context, it may be very difficult to do that, but it doesn't change the fact that someone is hyperventilating and has a profound dysfunction in their breathing, which can have a profound impact on their quality of life. And if someone is hyperventilating all the time, there is the risk of hypocapnia or blowing off too much CO2, which can have some very significant physiological responses, such as tachycardia, chest pain, exercise intolerance, fatigue, dizziness, or syncope. And so, those are all very significant. So being able to kind of tease out the root of where dyspnea is coming from, get it cleared, and then manage the breathing pattern disorder, which probably will present with other different things, probably deconditioning chief among them, is probably important. And just like as a side note down in the bottom, this is just kind of a measure of inhalation and exhalation. So hyperventilation is different than tachypnea. And so, because that's usually a low lung volume, whereas this is a higher than normal lung volume at a higher than normal rate. So if we look at how to intervene, it's again, symptom stabilization. We don't want to be exacerbating symptoms, and we don't want people to be kind of like creating a positive feedback loop of that hyperventilatory response to stimuli, i.e. activity. And so the breathing retraining goals are going to be to reduce hyperinflation. So they're breathing up and top at their IRV, so their inspiratory reserve volume, and that requires a ton of energy. So from an energy budgeting perspective, it's a very difficult place to be because it's very calorically demanding. So if fatigue is a crossover, you can understand how that would be a goal. Reducing respiratory rate to something a little bit more calm and normal, resetting your acid-base balance, breaking that habitual pattern, and then eventually being able to increase how much activity they can do whilst maintaining breath control, and then creating that self-efficacy, because feeling short of breath is arguably one of the worst feelings in the world. So if we can kind of wean people from that pattern and reinstate some control, that's a big win. And so just some basics on breathing retraining from a pulmonary rehab lens. Step one is communication and education. So oftentimes we will landmark the diaphragm for people. In non-diseased populations, breathing should be belly dominant. It should be slow. You can perhaps give some directional breathing, so using your hands to help facilitate directional breathing, starting in a supported position, so supine, and then maybe recumbent and supported, and move to a seated upright and then upright. Is a good way to be able to hound those foundations. And I know in the book and in the self-support document that's been created by AHS, there are some breathing drills in there. And I know that diaphragmatic breathing and pursed lip breathing is kind of on our radars as clinicians as like our top breathing techniques. In people that are non-diseased though, quiet breathing should be nose dominant. So they should be breathing in and out through your nose. And so just being able to be aware of that pursed lip breathing for all populations is maybe not the most salient. And then if they're not able to work greater than a 3 without spiraling with breath control, I would pare it back. And then again, creating breath awareness. So when people become aware of their breathing and what triggers dysfunctional breathing, what it looks like to them, is it their nose, their mouth, their chest, their belly? Are they panting? Are they controlled? What does their trigger look like? When does it happen? And how can they become aware of it in order to try and intervene on their own? You may find people breath holding. And so being able to encourage exhalation and blowing out when they start to spiral is really important. I went to a course and their big tagline was, when in doubt, breathe out. Fair enough. Okay, and then the last pillar is dysautonomia and orthostatic intolerances. So this is it's a range of clinical conditions characterized by your dysfunction of your autonomic nervous system, which of course is our involuntary nervous system, sympathetic and parasympathetic, which helps feed homeostasis in the body. And what we're seeing in a post-COVID context is orthostatic intolerance or postural orthostatic tachycardia syndrome, also known as POTS. And so the orthostatic intolerance is the body's inability to meet the demands of being in an upright position. And POTS is that increase in heart rate of greater than 30 beats per minute or greater than 120 when put into an upright position. Of course, this can also present with dizziness, weakness, presyncope, and heart palpitations. So if patients are demonstrating this, that meets the kind of threshold for cardiac symptoms as well. So probably needs to be investigated, but this is how the screening tool looks. Do you feel lightheaded when you change position? Do you feel unwell when you're upright or standing? And then kind of suggestions on how to screen and inform primary care. And when we look at interventions, self-management education is available. And so we're talking about position change, fluid intake, sodium intake. Maybe there's support stockings or compressive clothing that might help support some of that. Breathing re-education and activity pacing is definitely up there because it underpins everything. And we'll get into it a little bit further. And there is this definition that is gaining more and more traction, and it's that symptom titrated physical activity. Sometimes, like for example, if I worked orthopedics outpatients many years ago, and someone had like a hip replacement, they had a very clear protocol of what they need to do week 1, 2, 3, 4. And in this population, it is not so much the case. You are really guided in grading and progressing exercise exclusively based on symptom titrated physical activity. So if there was more than one time in a week that someone had to discontinue exercise or the programming available because of symptom recurrence or deterioration in symptoms, that would indicate that that is too much of an overload. And if they've been medically cleared by a physician, so they have this very clear diagnosis that we know we're managing, structured exercise and aerobic reconditioning and strength training can be considered for patients with POTS. And so perhaps you've heard of the Levine protocol or the CHOP or Dallas protocol. They have very similar kind of trajectories where you're moving from supine to an upright position. And again, you don't have a very clear-cut timeline on how that will be delivered. Is very symptom guided. And that's where the difference comes in with a post-COVID-19 population. And so again, you've got support for the non-upright exercising, especially for people who have had significant symptoms in standing. And I think this could probably also carry over for people that are in those kind of post-acute phases of COVID rehabilitation, even if they don't have this clear diagnostic criteria. I myself really enjoyed doing some supine Pilates because I couldn't do anything in an upright position well after I was sick. So I see some good carryover here. And then there's been some support for autonomic conditioning therapy to help reduce fatigue and improve symptoms. And so that is this idea. It's a very clear protocol that is available in a PDF online, and there needs to be more research into, whether or not in what dosage and how supervised and all of that. But it is very useful. And so how it's set up though is there's a 4 weeks of breath control and breath work and learning how to control your breathing and recovery breathing and just like very slow, gradual introduction of activity before you start to move them into that supine to upright. So it is something that's gaining traction. It is available widely across the US. And what underpins it again is breath work. And so again, a distinctive feature of autonomic conditioning therapy is your progression of your patient is not about time that has elapsed. It is about symptom guidance. And just to be aware that oftentimes that POTS presentation or dysautonomia is often present in conjunction with post-exertional symptom exacerbation. So again, you're going to titrate to symptoms, and you may want to consider a holistic treatment approach where you're dealing with all those other things that help stabilize your patient and try and support their best outcomes. And sometimes activity is not it. Sometimes you need to focus on sleep hygiene and pacing. So that's there. So just a post-COVID outpatient case study that we have had, and I think it just demonstrates the trajectory and the different factors of how people are not so linear, is in my realm, we had a 62-year-old male hospitalized last year with respiratory failure because of COVID-19. He spent 31 days in intensive care where he was proned, ventilated, and trached. He spent 83 days in hospital total, discharged home on 5 liters with pulmonary fibrosis on imaging, and he was referred to pulmonary rehab in August of 2020 and completed the program in December of 2020. And so this is just an image that kind of highlights how, yeah, he was referred to pulmonary rehab, but whilst he was being treated in our lens for pulmonary disease, there was also very clear brain fog present, like a difficult time synthesizing the content and being able to ask the questions that needed to be asked or pay attention for long periods of time. We were also working with WCB in a return to work, and this individual to date has not gone back to work. And then there was also the onset of new disease, so pulmonary fibrosis and supplemental oxygen use, and that is a very new world that requires a whole host of new learnings about what that means to how do you live with that. And so we're trying to equip him with all of these things and then simultaneously train him post a horrific hospitalization. And then of course we had to interact with the voice program because this individual also had, an upper airway injury as a byproduct of intubation and being trached. And then even to this day, we did his follow-up last week, and he's got persistent myalgias, which impairs his ability to exercise consistently, which of course can help facilitate deconditioning. He's presented to emerge 3 times in the last year for a variety of different circumstances, including MSK etiologies, and he's actively followed by greater than 4 specialists in a post-COVID context, and he's a new diabetic. So there's as a byproduct needing to be managed on prednisone now. So there's so many different pieces at play. And I think it highlights the importance of thinking laterally rather than in our silos, and leaning on the tools and the documents that have been created within AHS to help support the learnings, so you can best, be that primary care individual, but be able to consult with different resources that are made available for you. That's it for me. I will pass it over to Catherine.
Okay, so I just want to speak to some of the acute care experience we had at the Royal Alexandra Hospital, as well as to give the community an idea of how we were just trying to optimize function at the height of some of the illness that we saw with COVID-19. So many of our patients with COVID-19, we ended up in ICU. During some of the waves, we had COVID-19 units where we had enough patients that we needed to dedicate a staff and a set of physicians to that end, and also patients on medicine units who would come back COVID positive. So in the physio world, we were looking to optimize mobility and function. And as we learned throughout this 15-month time period, we needed to give early education, as well as debunking some of the myths that are out there on the internet. Surprisingly enough, the patients who were in the hospital still believed many of the myths that COVID-19 was just a flu. The next slide, please. So as I said before, optimizing function and mobility, and at the very least to their baseline so that they could return to home with a safe discharge. Collaboration with the interdisciplinary team was absolutely essential. For ensuring safety of the patients, we needed to liaise with the nursing and the medical staff, and also to use the specialties that we had at our disposal, everything from specialties within the physicians to the recreation therapists, the occupational therapists, and the SLPs, as well as respiratory therapy. So we were educating using the Alberta Health Services resources and the handouts as they arose. And in the meantime, using many of our information we have about managing breathlessness that Lauren discussed at length, as well as managing rest as an activity. Many of our patients during the height of their viral load and the height of their illness needed to use rest as a method for recovery. We also needed to promote the safe transition of care to other areas, such as rehab or to a local hospital. Many of our patients came from other regions and needed to be treated here with specialty care. So we wanted to ensure that safe transition, and also to make patients aware of the community resources as they arose and as appropriate. So a lot of what we were doing on the COVID-19 units is screening patients. It was ongoing and it was changing rapidly. So formally, we would speak with the interdisciplinary team, attend daily rounds. More informally, we would go into the rooms and speak with the patients to try and determine the appropriateness for physical activity, as well as the safety of doing it. So some of the other issues that we came across is that the relapsing, remitting nature of the progress that our patients make. So if one day we would mobilize the patient, the next day they may crash. Some of the psychosocial considerations that were brought up by my colleagues, the isolation in the hospital. We were not allowing visitors into the hospital, so the patients felt very isolated, as well as insulated. They were surrounded by other COVID-19 patients, and they felt that there was very little other than COVID going on in their lives during their hospital stay. Finally, to add to what Lauren was speaking about with the voice issues, we were finding that with the persistent cough that often accompanies COVID-19, as well as post-extubation, if the patient had an ICU stay, many of the patients had issues with their voice, as well as with swallowing. So then onto our assessment and intervention, we found it was highly individualized. So finding the right time and often having to be creative and flexible in the way that we provided our treatment. So we would try to organize it around the care being provided by the nursing staff, or more practical considerations of tests or needing to do basic functions. Close monitoring of vital signs such as heart rate, respiratory rate, O2 saturations, blood pressure, using perceived exertion as well as dyspnea. Essentially, the handling of COVID-19 mobility and physical activity was slower and shorter. We needed to move more slowly with the patients, more rest in between positioning. So from lying to sitting with a rest in the middle, from sitting to standing, and also shorter sessions. So again, we were attending daily rounds, talking to the COVID physicians and trying to avoid that, what has been called by my OT colleagues an energy bankruptcy. So trying to ensure that the patient is budgeting their energy appropriately and trying to meet them where they're at. So particularly pre-vaccination, we employed a primary therapist model to try and minimize the number of vectors. So not just for efficiency, but also for safety of staff and for patients as far as exposure to COVID. So it required quite a bit of understanding of the interdisciplinary team's roles and their responsibilities. As primary therapist, if I felt that my abilities were exceeded, I needed to identify that and bring in the appropriate specialist. Collaborating with the respiratory therapist is absolutely essential. As soon as we identified that a person was experiencing difficulty with breathing on exertion, even the most basic exertion, the respiratory therapists were an excellent resource, and we continue to use them with that and try to collaborate our treatment whenever possible. Some of the measurements used in the hospital to determine needs for home O2 include pulmonary function tests, as well as arterial blood gases. These two tests were often coming up as normal in COVID-19 patients. And so we were finding that they were not sufficient to determine the oxygen needs of our patients upon discharge. So then we were turning to things like exertional oximetry strips that would show us whether or not a patient would benefit from oxygen at home upon discharge. And I'll speak to that a little bit more during my case scenario. Next slide, please. So the following IPC policy, so that's infection prevention and control, we were told as hospital workers, the thing you do perfectly is your PPE and your infection control procedures. So we had to make sure that we were wearing everything correctly, particularly when we were going from patient to patient to reduce the risk of transmission. Anytime we saw a patient, we needed to have a plan B, C, perhaps even D or E in the event that that patient decompensated and crashed mid-treatment with something as simple as sitting on the edge of the bed. We were using many breath techniques such as the breath control, the huff versus the cough. The huff versus the cough was quite beneficial for patients experiencing a persistent cough to help them control it. And educating patients about the effects of persistent cough and having hypoxia was also very beneficial to help these patients manage their cardiopulmonary status. And we're still learning, we're still adding more things to our tool belt, and we're always trying to do better. Next slide, please. As far as functional cognition, I defer to my OT colleagues in this regard in many cases. However, we were experiencing difficulty with educating patients due to the brain fog and due to being generally overwhelmed by having COVID and the hospital environment itself. A lot of people felt sleep deprived, stressed, anxious, particularly the patients who were out of work at that time, who couldn't return to work, who have families, or perhaps are caregivers themselves. So trying to be mindful of that, our COVID units were using iPads to try and help these patients communicate with their families and to interact with the outside world. Also using just phone chats for patients to be in regular contact with their loved ones was quite beneficial and became a part of the physio treatment, just to try and educate and to try and have another person present for some of the education when the patient is in a brain fog. And our rec therapy colleagues addressed some of the needs we had in the hospital, that once COVID-19 set in, many of the resources we had for stimulating patients cognitively were not available, such as newspapers and books. We were not disseminating that sort of thing due to infection. And so the rec therapists put together packages for patients to use to try and reduce their anxiety and the feelings of helplessness that were coming with the height of their illness in the hospital. Next slide, please. So here's some pictures of the documents that we were using. And we actually put together a one-page document to give out to patients upon admission to the hospital with COVID-19. And the nurses were instructed to identify if patients had any questions about any of the categories about getting healthy after COVID-19, then we could bring in the appropriate specialist to discuss it with them. From a rehab perspective, as physio, we were discussing the 3 Ps, the pace, plan, and prioritize, as well as the pursed-lip breathing, giving out resources such as the rehab advice line and the different clinics and different programs available for having rehab after you've left the hospital. On occasion, we were giving out home activity programs. However, we found that basic ADLs were often the maximum amount that the patients could accomplish prior to discharge from hospital. So we were often giving out resources from the community as a next step for patients to get to once they have been home for a while and been able to recover further. We're also educating the nursing staff and the medical staff about the role of rehab, and some of the information in this document that pertains specifically to physiotherapy was not known to the medical staff, and they were able to support us quite a bit in that regard. Next slide, please. And from a discharge planning standpoint, having patients from all over the province and trying to navigate the systems and the different things that patients had access to became very important. Collaborating with the social worker as well as the transition coordinator to ensure patients had funding for these programs and that they could have a smooth transition to home and someone to contact in the event that they didn't know what to do. So that minimizing risk of patients falling through the cracks and making sure that they could get support and that they would try to gain access to it as soon as needed. Next slide, please. So this takes me to our case scenario. We had a 50-year-old female admitted to the ICU due to COVID-19 pneumonia. She spent 10 days in the ICU and was intubated. On day 11, she transferred to my unit on 10 liters per minute of oxygen. Initially, when I saw her, she had a persistent cough and became very short of breath with just merely sitting on the edge of the bed. If she tried to sit in a chair, she was not able to maintain that for longer than 5 minutes before she was desaturating below 90%. However, the nurses were working hard to wean the patient from oxygen. And so by day 14, she was on 2 liters per minute of oxygen. Interestingly, with mobility and transfers, we needed to titrate her oxygen to 3 to 4 liters at that point because of the persistent cough and the shortness of breath, even with the slightest amount of exertion. So by day 15 to 20, the nurses had titrated the patient down to half a liter of oxygen to maintain a 92% oxygen saturation. And by day 20, the patient was able to do the 10 steps that she needed to get to the 2nd floor of her townhouse, and also able to ambulate 20 meters on room air. So the ABG was normal prior to discharge. It was completed by the respiratory therapist to determine whether or not the patient needed home O2, and the patient was sent home without oxygen. From the rehab team, the patient was given the handout that I referred to earlier with access to the COVID rehab resources from Alberta Health Services, the rehab advice line, also the phone number of the unit in case she had any questions. This patient was feeling quite a sense of urgency to get back to work. So there were considerable questions about return to work, which I answered as well, and is one of the reasons why she left on day 20. She might have stayed in the hospital longer otherwise. So the patient was discharged on a weekend, and by the next day post-discharge called the unit to say that she was very short of breath and that she had purchased a portable oximeter that showed her oxygen was below 90%. So she was instructed by the unit to contact a home oxygen company, but was also told that because the ABG was normal in the hospital, that she may have to pay privately for her own oxygen. And in fact, that was the case. She did need to pay for her own oxygen. So what have we learned? Well, I'll refer back to what I said earlier about the exertional oximetry. If we had involved the respiratory therapist earlier for an exertional oximetry, perhaps we could have identified the need for oxygen in the community. And we're always learning, so we're now instituting an exertional oximetry, and it's in the hopes that we can better advocate for these patients and prevent them having to return to hospital.
Thanks, Lauren and Catherine. I know we're running a little short on time, so I'll try to get through the next section quickly, but just wanted to give everyone a reminder of the resources that are available. Again, these can be found on our internal SharePoint site or on the external provider resources site. The webinar recordings will also be located there, and you can find them by clicking on the schedule of webinars, and we'll include links to both the PowerPoints and the presentations in that area. I also wanted to take a moment. These are the links to those sites I just mentioned. And then we just wanted to take a moment to highlight the Rehab advice line. So for those who aren't aware, it's a really great service that's provided provincially, and it helps clients with navigation and wayfinding and some of the self-management education around COVID and other conditions. So certainly knowing that our rehab criteria is kind of changing and being reevaluated, we would recommend people consider this as a resource, because we want to make sure that patients, when they leave acute care or in the community setting, that they get directed to appropriate rehab programs and services in their area. And last but not least, just wanted to highlight the additional webinars coming up in the series. So next week we have our colleagues from psychology, spiritual care, and social work presenting. And then there's 3 other sessions after that. So I encourage everyone to participate and attend those if possible. And then we'll open it up to the group for questions. I think Laura's going to moderate this section.
Thanks, Caitlin. Yes, we have a few questions, so we'll see how many we can get through in the next little bit. This first question is from a therapist, sounds like in an outpatient area, had a patient post-COVID whose goal was to walk to a nearby shopping area, use the 6-minute walk test and constant pulse oximetry. The patient had no increased shortness of breath or perception of exertion, but at the same time, her oxygen saturation would drop while walking to the upper 80s, so still well below 90. The therapist would ask the patient to rest, and she would say she could keep going. So the question is, what is an acceptable number for oxygen saturation drop when there are no other red flags present?
Great question. Excellent question. I'm gonna answer this. It's really important to recognize that someone's dyspneic presentation or the perception of being short of breath is not linked to oxygen desaturation. Frequently, there are people that can drop to the low 80s and high 70s and not even be aware that it's occurring. And so, someone's shortness of breath is not a very good marker on whether or not they are exertionally desaturating. What it sounds like is this individual is desaturating, and if they are below 90 with exertion, then they need to be sent back to primary care to be worked up. If this person is on oxygen, so Laura, I heard you say like pulsed, did you say pulsed oximetry or pulsed oxygen flow?
Yeah, I think it was the pulse oximetry.
Okay.
So there's SpO2.
Okay, so if their SpO2 is dropping below 90 on exertion, they need to be worked up by primary care. And they need to kind of go through that process, because if they qualify for supplemental oxygen, then they should be on supplemental oxygen. Most people don't desaturate unless there is an impairment present. And if their breathing is within normal volume and rate, and it's not like a hyperventilatory or tachypnic presentation in light of exertion, then they need to be sent back to primary care. And again, rehab intervention should not induce desaturation. So if they need to be supported with supplemental oxygen, then there's that. And if they don't qualify for oxygen, then it's about pacing. And there needs to be that education for the patient. We do this often in pulmonary rehab of trying to relay the importance that just because you feel well and you feel like you could keep going does not mean that you should, because you are objectively desaturating. And we know as soon as you start dropping below 88% in the context of lung disease, maybe even 90, but 88%, the first organ that takes a beating is your heart, and the second one is your brain. So that would be my take on it. Is if they're dropping to like the mid 80s and their complaint is that they feel fine, that's not a good measure of whether or not that's safe.
So Lauren, would you still say anything below 90? In a normal patient with overall healthy, no other?
Yeah, like why are they dropping below 90? You know, there's not really like there's not just like oh, I woke up one day and I dropped below 90. It's like there's something else happening that they're below 90. So they need to be sent back to primary care, have those red flags ruled out. And if they don't qualify for supplemental oxygen at that point, then it becomes pacing, breathing retraining, and maybe general fitness in a supported environment so that their oxygen demand peripherally is lower so that they can do more with less.
Thanks.
You bet.
The next question is about screening for shortness of breath and the challenge of screening, or how you would recommend screening for shortness of breath in a mental health setting with patients that have chest pain and shortness of breath related to their anxiety.
Well, I will not profess to know anything about anxiety because that's not my bag. But I will say that if you can have them worked up to the exclusion of any of those other underlying sinister causes, then that would probably be the number one priority. If people are short of breath because of a feeling of anxiousness, then I would work with whatever mental health team or social support, psychosocial supports you have available to help address that. But as long as you're clearing them from a safety perspective, like a physiological safety perspective, then I guess that's all you can do.
The next question is from a speech language pathologist, and it's around the screening tools. And the question is, would you recommend to use these tools before initiating dysphagia exercises? Or are these just for whole body exercises or exercises that would increase heart rate or breath rate?
Great question. Not a speech language pathologist, so I will not answer it from that lens, but I will say that any kind of exercise or induction of rehabilitation intervention can cause cognitive fatigue, and there can be some other kind of physical fatigue. And so if someone is presenting with post-exertional symptom exacerbation, then I think that helps inform the intensity with which you treat. I think from this SLP's lens, like what they're managing is like plus important. And so I think it's just making sure that your intervention is titrated below the level of symptom recurrence.
Thank you. There is a couple more questions, so we'll see how it goes. This next one is for Catherine, I think, and it's a curiosity one. What do you say to patients when they express that their belief is COVID is just a flu?
That was a tough one. It surprised me the first time that I heard it. And so I explained to them basically what their course of illness had been since they were there. So if I think of an example, one gentleman came in and he needed 1 liter of oxygen on the first day. And when I saw him on the 4th or the 5th day, he needed about 10 liters of oxygen. And he was still saying, I just think that I have the flu. And so I explained to him that, 10 liters of oxygen is a significant amount, and that he may or may not realize that he's being managed by a full team. So I described the interdisciplinary team. I told him how many people were involved in his care, and that we don't accept patients in the hospital unless it is quite severe. And this is not typically how a flu goes. And from then on, I would just try to acknowledge meeting the person where they're at is really what I wanted to do without being disrespectful. And that was a real challenge.
Thanks. So we're at 12:30 now, and I want to thank everybody for joining us today. These sessions are recorded, and the recording will be posted for folks who aren't able to join. And we look forward to seeing you all next week for the next session on psychosocial and spiritual perspectives. Have a good day.